wild type and pediatric GIST. So the succinate dehydrogenase members are important in the Krebs cycle. So if you have loss of SDHB, you have to test if, for example, the mitochondrial, the SDH complex 2 activity is maintained or not. And this bar chart here shows that in wild type and pediatric, just the complex 2 activity is completely lost. Of course, you want to correlate if the loss of SDHB expression and SDH function correlates with the presence of SDH mutations. So due to the very large collection of pediatric and wild type GIST that was collected by Soo Kim, which was part of the pediatric NIH clinic, we were able to study 34 wild type GISTs that none of these patients had personal or familial history of paraganglioma, and 4 of these patients, or 12%, were found to have germline SDH mutation. So they had SDH mutation in the blood as well as in their tumors, and 3 of these 4 were in SDHB and 1 was in SDHC. There were no mutation found in SDHD and SDHS. So in summary, this study shows that in wild type GIST there is a complete loss of SDHB protein expression compared to the KIT mutant GIST, that the SDH mitochondrial complex 2 activity is significantly decreased or lost, and the germline SDH mutations were identified in 12% of wild type GIST without a history of paraganglioma, suggesting a potential role for SDH dysregulation in wild type and pediatric GIST oncogenesis. And this was really a very good example of our collaborative effort of scientists and how to take advantage of such a collection of tissue, rare samples. So Mike is going to update us more on this, but was a really wonderful collaborative effort that our lab was really lucky to participate, and the molecular work was really divided. We took part of the SDH and we sequenced in our lab, and at least we have some clues for a subset of pediatric and wild type GIST. And for the few minutes left, I just want to briefly update you with our efforts on the deep sequencing or next generation sequencing that is promising to provide opportunities for a more comprehensive analysis of cancer genome. And we think that pediatric GIST is a very good example that this new technology can be applied to identify more targets. So just a little bit of background about next generation sequencing. Obviously, the capacity of these platforms is huge, more than 1 gigabase per run. Because of this automated high throughput sequencing effort, then the result is a dramatic decrease in the costs per genome, and it can be applied not only to DNA but also RNA and chromatin. So because of your gift, we were able to study a few pediatric GIST samples, and the starting point was 5 micrograms of DNA that was first put on an Adjuvant platform, and only the coding region, the exons, were captured, which is called the exome capture step, and then was followed by the solid sequencing. There are 2 different platforms available. Our institution has embraced the solid platform for deep sequencing. And just to give you an idea of how this works, each of these numbers is a nucleotide of the pediatric, let's say, tumor, and each of the nucleotide or the base is being interrogated by two different primers. Each of these rows is a different primer by two different ligation reactions. So the depth of interrogation of these mutations is very high. That's why it's called deep sequencing. And now the only downside to this tremendous amount of information is the bioinformatic problem that sometimes there's too much information and it's very difficult to come up to the softwares that are able to pick up all these single snip from, let's say, noise. So what we have so far, we tested 6 pediatric GISTs on this platform, and very exciting, 3 of these show SDHA mutations, so the same family, the succinate dehydrogenase A in exon 2, 3 of them. We need to validate to make sure that this is not just a software error, so we are doing now the PCR to confirm these mutations in tumor as well, to make sure they are not present in the normal. If they are present in the normal, then the possibility of a germline SDH mutation, of course, has to be considered. And if these mutations are being confirmed, then we are going to extend this to a larger cohort of wild type and pediatric GIST. This is not the only hit we got. We have additional mutations that were detected that need to be validated, and hopefully next year you will see more interesting results. So of course I have to thank all our memorial colleagues, Peter Besmer and my lab, 3 of them being here, my clinical colleagues, and the update of my son. Thank you. Any questions? If not, I will ask Ron to, I think he's next.
So I thought I would give you a combination talk. The first half I think is pretty understandable. The second half is a little bit technical. So the first half is about humans, and the second is what we're doing in the laboratory. So we have a couple of drug representatives here. So Imatinib and Sunitinib and Sorafenib and all the other IBs are generally not curative in GIST. In some patients, the drugs can obviously last very, very long times. But in general, we don't think of these drugs as curative. The drugs can kill a very, very large portion of a tumor, but in general, there's some cells that remain, and in some patients, those cells remain quiescent for long periods of time. But in many other patients, as you know, the cells wake up again. So, this is really a summary of the first decade of tyrosine kinase inhibitors and GIST, and most of the focus has been on, well, what new tyrosine kinase inhibitors can we make, and how can we use them in combination, and that's probably one of the more likely ways that we're going to get out of this conundrum where we have these great drugs, but they're generally not curative. But we've taken a little bit different approach, because, as Tanya said, everybody sort of adds something different in the team of GIST investigators in this country. And so our strengths were in surgery, number one. We've recommended doing surgery for selected patients where we can see a small amount of residual tumor, and we take out that residual gross tumor, and we then put them back on the tyrosine kinase inhibitor. So we've been one of the leading groups in the world that's really gotten a lot of people to take this approach. 10 years ago, everybody laughed at us saying to do this, and now it's quite common. The next thing that we've worked on is adjuvant imatinib, and that's what I'm going to talk about. So instead of the metastatic setting, or where there's multiple tumors, we said, could we take patients who had their original tumor and try to prevent them from ever having their tumor come back? So that's called adjuvant therapy. And then the last part is the lab part, which I'll get to. So this was the trial that we ran. It took a decade almost to run, and we designed this in 2000, so we didn't know that much at the time. So we just said, well, any patient who's got a 3-centimeter tumor, and they can undergo complete resection of that tumor. And then the patients who took part in this trial were great, because this was a double-blind trial. The standard of care at the time was to do nothing, so that's why we felt that including a placebo arm was legitimate, because that was the standard of care. And then half the patients got Imatinib instead of the placebo. And it was as fair as we could make it. If somebody developed a recurrence on placebo, then we would give them Imatinib. And remember, at this point, Imatinib was not commercially available. It was only available through a clinical trial. And we had about initial plans were for about 380 patients, because we figured we'd barely get that. And what eventually happened when the trial got up and running was we were accruing a patient every other day in the United States. And so we doubled the size of the trial, and eventually it went to over 700 patients. And what we found was this, and you're not used to looking at curves, but I'll try to help you. So at the beginning of the trial, at time 0, meaning the day that you entered the trial, 100% of the patients had no evidence of tumor, because they just had an operation to remove the single tumor. And then this, over time, over months, some of the patients develop recurrence. And every time a recurrence happens, the line drops by a little bit. And so what you can see here is the blue line was Imatinib, and they only got the drug for 1 year. So in that year, almost nobody developed a recurrence. This is very striking for clinical trials. Whereas if they got the placebo, about 18% of the patients at the end of 1 year had already developed a recurrence. And what you can see here is that even though they only got a year of Imatinib, the patients who got Imatinib got even more protection than 1 year. They probably got at least another several months. But eventually, several of them, many of them, started developing recurrence. So again, this emphasizes the theme that there are some patients who get cured by this drug, but many don't. Many just have a small residual amount of tumor cells that go to sleep. And we're trying to update these data. So by clinical trial standards, we haven't really had a long follow-up yet. This is only about 1.5 years of follow-up. And what we see so far is that there's no difference in how long the patients live, because the patients who developed recurrence got Imatinib and got rescued by Imatinib in general. Most of them would respond. And so everybody, very few people have died on this trial, even though there's 700 patients and we started the trial 8 or 9 years ago. So we're hoping to have some more data in the next couple of months to say what happens after many years of follow-up. So this trial turned out to be the pivotal trial for the world. The FDA approved the drug, and they approved it as open use. Pretty much anybody could get the drug now, and it would in general be paid for by the insurance company, so you didn't have to be in a clinical trial anymore. And then following the FDA approval, the European Medical Association, which dictates what happens in many other countries, even outside of Europe, also agreed that this was a legitimate treatment. So the question then became, well, who should we give the drug to? We know that if we give it to everybody that walks in the door, we can show a difference. But, of course, if you saw the graphs I showed you, many patients never developed a recurrence, even on the placebo arm.